So, good morning, everybody. My name is Jamie Saeed, and I am a fourth-year medical student at Alabama College of Osteopathic Medicine. I am working in conjunction with the residents and attendings at Thomas Hospital at Fairhope, Alabama. And today we are presenting a case of Sézary syndrome in an elderly Caucasian male. Let me see. Okay. So I'm going to go ahead and start off with an introduction. I'm going to talk about mycosis fungoides, and it is basically a T-cell lymphoma that can progress to its chronic stage, a T-cell leukemia called Sézary syndrome. Most physicians think of it as a timeline. Eventually, the lymphoma will turn into leukemia and be called Sézary syndrome. The presentation consists of a varying range of a pruritic cutaneous eczema-like lesion that's chronic for the most part. Patients present with a year to 2 years of this condition that's non-retractable to treatment. So supporting the diagnosis of Sézary syndrome includes the characteristic cerebriform lymphoid cells on skin biopsy, peripheral blood erythroderma, and lymphadenopathy. For the most part, therapeutic targets include phototherapy, skin-directed topical treatments, as well as steroids, chemotherapy, and retinoid like paroxetine to treat chronic invasive cancers. Monoclonal antibodies, as well as interferon alpha, are also given for relapse cases. So here we present a 70-year-old Caucasian male with a history of AFib, type 2 diabetes, hypertension, and PAD. He presented with a chronic 1-year generalized body rash that persisted with no improvements despite various topical treatments. He has no history of these symptoms other than chronic stable fatigue. On physical exam, he had a generalized erythematous rash over the chest, trunk, and extremities. There was no organomegaly, no adenopathy, as well as any other systemic findings. We did do a biopsy of his skin, and it did reveal a diagnosis of mycosis fungoides. We therefore subsequently did a bone marrow biopsy, and it did reveal Sézary cells. Okay. We did a PET scan on him, and it did reveal a hypermetabolic lymphadenopathy in the mediastinal, bilateral hilar, and upper abdominal regions. So it did show signs of metastatic progression. We subsequently started on paroxetine, which is a retinoid, and topical steroids for the treatment of Sézary syndrome. And today, thankfully, he remains clinically stable and no worsening skin rash or new B symptoms. Here's how the cutaneous manifestation of Sézary syndrome looks like. And this is top and below, you'll see what a Sézary cell looks like on electron microscopy, where you can see the infolding in the middle here in the cell, typical of Sézary syndrome. Little bit of discussion. So again, mycosis fungoides is the lymphoma stage, T-cell lymphoma stage of this type of cancer, and Sézary syndrome is the leukemic variant of this type of lymphoma. It usually consists of less than 5% of cutaneous T-cell lymphomas, so it's pretty rare. Sézary cells in the skin are distinguished through cytopathologic assessment or flow cytometry. Treatment includes chronic systemic disease, is aimed to control the chronic systemic disease and skin involvement. And for the most part, you're going to give retinoids like paroxetine, monoclonals, methotrexate, interferon alpha, and other types of retinoids. You can also try to treat the cutaneous manifestation through UVBs and topical steroids. Now, despite several treatment options, most treatments do not result in a long, durable response. Advanced diseases physicians should start to think about allogeneic stem cell transplantation in advanced diseases, and the median survival is it's about three years. Prompt diagnosis is an evaluation of symptoms, including skin rash, is vital. So internists should start, turning on the gears in the head when they see a patient with a chronic 1 or 2 year pruritic skin rash that has not improved with topical treatments and so forth. In conclusion, Sézary syndrome is a combination of a lymphoma stage and a leukemic stage, mycosis fungoides plus the malignant T cells in the blood. Early lesions of Sézary syndrome are clinically indistinguishable from dermatitis. So anything chronic should point to a more in-depth analysis, histologic diagnosis, biopsies, etc. And the primary treatment for these are steroids, chemotherapy, and retinoids like paroxetine. Here are my references, and then I would like to thank Dr. Ipedeng, Dr. Mack, and the SMA for this wonderful opportunity and collaboration. Any questions?
There's one question. How is the patient doing now?
So the patient has definitely improved. His rash has decreased. There's still a little bit of erythema and itchiness, but it has drastically improved since start of chemo and the retinoids. So pretty good in terms of our patient scenario.